Welcome to the PIBD Digest. This podcast explores pediatric inflammatory bowel disease, including Crohn's disease and ulcerative colitis. We're your hosts, Dr. Chris Bakewell and Dr. Tracy Coelho. In each episode, we'll discuss a specific aspect of pediatric IBD with an expert guest.
This podcast is intended for healthcare professionals involved in the care of children with IBD, as well as for patients and families seeking to better understand the condition. The views expressed are those of the speakers and should not replace professional medical advice. As this episode goes out, the global situation feels especially fragile. Our thoughts are with all those affected by the conflict and uncertainty around the world.
Welcome back, everyone, and thank you for joining us once again. So today I have to start by saying a big thank you to all of our listeners. Many of you are now international, but also several of our very own IBD patients' families here in Southampton. I must say that when Dr. Coelho proposed this pediatric IBD podcast to me, I didn't quite expect it to have the reach or appeal which it seems to have gathered. Hopefully you'll all continue to find this a useful resource, whether you're a patient, a clinician, or a family member, and of course, keep listening. What do you have to say to that, Trace?
Well, firstly, I'm genuinely grateful to every single one of you tuning in, whether you're listening on your commute, working out in the gym, or pretending to finish paperwork. The fact that we now have listeners across different countries and that families and patients are tuning in as well, that's incredibly humbling. And thank you, Chris. I suppose behind every good podcast is a co-host who keeps things structured while I occasionally wander off into enthusiastic and poetic tangents. Also, I would like to mention that this week actually marks the anniversary of our podcast. So I think it calls for something really special.
Today we're taking a break from our IBD World Tour because we'll be joined by one of the leading researchers and voices in pediatric inflammatory bowel disease. He's another member of the Porto IBD group for Espegan and lead author of so many PIBD guidelines and research studies. It is, of course, none other than Professor Dan Turner. So Tracy, we may have to keep the puns to a minimum and let the science do the talking.
As I always do, Chris, restrained and scholarly at all times. But in all seriousness, Dan is one of the true heavyweights in pediatric IBD. He has shaped guidelines, driven pivotal research, influenced how many of us practice day to day. So yes, today we sit back, ask good questions, and let the science take the center stage.
And we actually have so much to ask Professor Turner that this episode will form part of a two-parter mini-series. In this first episode, we're going to start with some of the fundamentals of pediatric IBD treatment. Then in part two, we're going to spice things up and get a bit controversial. We'll be talking about the novel approach of using dual biological therapies, or as they call it, advanced combination therapy. So, we think both episodes are essential listening.
And what better way to mark our pod anniversary than with someone who has helped shape the very foundations of modern pediatric IBD care.
Right, let's not waste any more time on chit-chat. I'm eager to get going and squeeze every last drop of knowledge from this guy.
Right, let's get going then. When browsing for IBD wisdom, the name in bold that seems everywhere, guidelines, research, or clinical scores, the score is now widely used to measure colitis flare. The man, the myth, the legend of IBD care, the Solomon of IBD wisdom, we hereby declare. Ladies and gentlemen, please welcome Professor Dan Turner.
Hi Tracy, hi Chris. Wonderful introduction, a bit pretentious. I'll accept these titles when I bring world peace or solve the global warming. Until then, just being in the right place with the right mentors and saying yes to all opportunities despite associated with hard work.
No, I think with a distinguished career like yours, you got to wear the crown, so...
Yeah, thanks for joining us.
Pleasure to be here.
So for our listeners, Professor Dan Turner, or Dan, is a leading international expert in pediatric gastroenterology and one of the most influential clinicians and researchers in pediatric inflammatory bowel disease. Based in Jerusalem, he leads the Juliet Caden Institute of Pediatric Gastroenterology and Nutrition at Share Zadak Medical Center and serves as Vice Dean at the Hebrew University Faculty of Medicine. He's a pioneer of several essential pediatric IBD clinical tools, most notably the PUCI score for ulcerative colitis, which we all use routinely in our practice. And he has co-authored foundational frameworks such as the Paris classification and the revised Porter criteria, which now underpin global standards in pediatric IBD diagnosis and disease monitoring. Publications? I won't even go there. I would fall into a bottomless pit and never be heard from again. So Dan, how did this all happen? What or who shaped your path to becoming such an influential global figure in the field?
Well, as I said, the introduction is too kind. Send the link to my mom; she'll be happy. But it seems as it was a pre-planned journey, that you know what you're doing in order to have some influence, or you want to hope that you've done something good to someone in the world, because that's what drives our efforts in the end. That's what we do. But in practice, as I said, it was having good mentors. Specifically, when I started at Sick Kids, I had Nicola Jones, and then my everlasting mentor and friend, Anne Griffith, that I just checked last week, and we saw that we co-authored together 99 papers. I emailed her quickly. I said, we need one more. And mainly very hard work. So when you have a lot of opportunities, you say, oh, I'm so busy. And I remember doing my fellowship course in North America. We had a whole talk, and the title was How to Say No. And it started, I still remember the beginning of the talk. It was one slide, open your mouth. Next slide, say no. Next slide, close your mouth. And I looked at it and I said, not so sure about that recommendation, because now when I'm more established and I'm doing lots of things and I have many opportunities, now I have the privilege of saying no to things. But in the beginning, you don't have privilege like that. I mean, you want a lot of opportunities and you never know what one leads to another. And so it's a lot of work, because there's 1,000 reasons why not to be involved in new initiative and new research and collaborative and other academic projects that are evolving. There's only one reason why to say yes. If you want to be part of changing the landscape of pediatric IBD or whatever thing you're doing, then that's the only way forward, and it's a lot of work. So people need to choose that.
Yeah, thanks, Dan. It's a pleasure to be joined by someone so passionate, and I think a good call to arms for some of our junior trainees that are listening. Maybe you can say yes to a lot of things at the start and then, sit back a little bit. So we've invited you on for a reason, and we're desperate to pick your brain and share some of that wisdom that you've clearly built up over many years and such an impressive career. One of the things that Tracy and I are obsessed with and have been on a journey around the world in recent podcasts is about PIBD incidents and global rates and what's happening to them, as I'm sure you are as well. And Israel, as many of us will understand, is known to have one of the highest reported incidences of pediatric inflammatory bowel disease globally. Your group has contributed massively to understanding those patterns. Would you be able to give us an overview of the current trends of pediatric IBD, specifically in Israel where you're working? How does that epidemiology look, and how has that evolved over the last decade or so?
So as in all the Western world, prevalence is increasing in Israel, where the incidence is stabilizing. And the reason why this is happening is because Most people do not die from IBD, although mortality rate is a little bit higher with IBD, but generally people live with IBD. So still, because of the increasing incidence in the last few decades, we're still seeing the increase of prevalence because there are new patients all the time. And with time, it's going to stabilize, and that is the last stage of epidemiology of IBD, of prevalence equilibrium. No Western country has reached that stage, and therefore the prevalence is increasing everywhere in the world. Also in Israel, we are now at around 0.7% of the population, and we just participated in a global effort led by Gil Kaplan. Some of it was published in Nature, and others in international conferences with simulation of what will happen in the next 10 or 20 years. And there are also data from Scotland suggesting the same thing, that it will stabilize between in Western countries between 1% and 1.3% of the population. So that's what we're talking about, 10 to 20 years. In India and China, the estimation is maybe more closely to 2 million patients in these two countries. In 15 years, we are heading towards 10 million only in these two countries. And that's huge. I mean, the burden of evolving countries and evolving medical care, and the cost of the biologics and the combination of biologics, it's we need to be better in what we do, because we are facing a big storm.
Yeah, massively. And I think, clearly your research is contributing to that. So given how many patients we have and how many patients we're going to have with inflammatory bowel disease, what we wanted this first of two podcasts to be with yourself is a touch on a lot of the important issues with treatment with inflammatory bowel disease, the things that our patients care about, the things that the clinicians listening care about when they're managing these patients. So as pediatric gastroenterologists, we're obviously very familiar with the role of diet. It's the question that our patients ask perhaps most commonly. I can talk to someone about giving them biologics, which can give them an 80% chance of remission, but their next question will be about what they should do with their diet. And for a long time, that question was difficult to answer. Perhaps it's becoming more clear. We're obviously very familiar with exclusive enteral nutrition as an established therapy for Crohn's disease, but that requires at least 6 weeks, maybe 8 weeks of specialized formula. Can be very challenging for families, especially given that you're not eating anything else. With increasing interest in whole food diets for IBD, would you be able to walk us through your recent randomized control trial that termed sort of tasty and healthy, I think it was, the non-ultra processed diet for mild to moderate Crohn's disease?
Yes, thank you. So I think the entire world, including the adults, are starting to move away only from formula-based intervention. Although it's still there for the sicker patients and the more complicated, I start EEN, but I do not do 6 to 8 weeks anymore. I mean, very quickly, even in these patients, I move to introducing whole food diet much sooner once the patient has been stabilized. There is the CDED, of course, that I'm sure all listeners know about. It's partial enteral nutrition with whole food, and that really revolutionized our way of thinking about the nutritional therapy in IBD. However, it still involves formula. And this is a burden not only on where formula cannot be afforded by many of the patients if there is no universal plan, but also this is burdensome for the patients themselves. And what intrigued me, there is a randomized controlled trial coming from Rabin Hospital in children and adults that randomized people to see that with or without formula. It was more or less the same, with the same outcome. So the question is, can we have the same effect without formula at all, and that's where Tasty and Healthy comes in. It's a diet that we were using for the last 15 years in our patients. 10 years ago, it was published in a recipe book. It's still on Amazon. It's called Tasty and Healthy. Great recipe. I have no problem to market it because it's a charity book, and all proceedings go to the support of children with IBD. But after we published it and we started using it, and we published a case series with reducing calprotectin, we started a Hensley funded set of 3 randomized controlled trials, one in mild to moderate disease versus EN, and the other in asymptomatic patients but with increased calprotectin versus just continue the habitual diet. And this is important because we have many patients that you give anti-TNF or other biologics and you get 80% response and they're feeling good. Asymptomatic, the inflammation is way better, but you do calprotectin is 300. Ultrasound has a residual inflammation. And when you do endoscopy, there's 4 centimeters of residual ileal inflammation. And there's always this itch saying, do we gamble by changing to another biologic, and maybe even the 80-90% response we got we will not get now, or to add something? And this is where the diet comes in. And responders from both trials, meaning deep remission, calprotectin normal, were enrolled in maintenance trial, where after 8 weeks we reintroduce gluten and dairy gradually to see what happens in the calprotectin. So more or less Tasty and Healthy, in the first 8 weeks, you exclude processed food, anything that comes from a can or bag. There are exceptions to that. Animal fat, so that will be meat, red meat, and dairy and gluten. And after 8 weeks, you reintroduce the dairy and gluten. 53% of the patients can reintroduce both, and calprotectin remains low. 1/3 can introduce either, and one of them will increase the calprotectin. And what we found in 90% of these cases, when you exclude again the food, calprotectin normalizes. So definitely this is a personal thing with the microbiome. We're now looking at all the omics. Before we published the next set of papers, one was published in Gastroenterology last year, and one is under review or under revision with another paper. So there will be more and more coming, not only on the clinical side of this intervention, with 70% clinical remission and 30 to 40% biologic remission, really similarly than what we had with EN. And this becomes a feasible alternative in many patients. I would still want a word of caution, whether this is Tasty and Healthy or Mediterranean diet or CD treat or seeded. It's not suitable for everyone, not only in the response rate, but also there are some families and sometimes parents are pushing, and this is not suitable emotionally to some of the patients, and we get more R-feed and feeding disorders in these patients. And when food becomes a topic of thought and discussion throughout the day, not only when you're hungry, then consider treatment and backing away, because we can do also harm in this intervention. So in the end of the day, it's a tool. You have to tailor the right tool to the right patient with shared decision making to give them alternatives. And the medication, certainly it's not a rude word. It's just the diet. It's just another tool in our toolbox to tailor to the right patient.
Yeah, that's fantastic and really well said, because I think that for me, I read that paper recently, and it almost a paradigm shift in my own strategy for managing patients, because very often I feel bad about the burden of treatment on our patients. A lot of this kind of top-down therapy, starting strong, getting things under control with a lot of medication. And when the families ask me about diet, I try not to go too hard on the diet, because I think that we're changing their lives so much. But actually encouraging a healthy, non-processed, reduced animal fat diet, maybe reduced dairy and gluten as well, as you said, might give some additional benefit or some sustained treatment response. I don't know. It seems much more clear now to me, having read your paper, than it did before. So I would really encourage listeners today to go away and read it and pick through that data?
Thank you. What we found with the microbiome, and that strengthens what you said, is that EEN resulted in a whatever we call bad microbiome, whatever that means, but anyway, more pro-inflammatory bacteria and less diversity, where the tasty and healthy resulted in increase of anti-inflammatory bacteria, decrease in the pro-inflammatory and larger diversity of the bugs. So if you do that over time, potentially you also have better outcome of the patients in regard to long-term complication. But this remains to be proven.
Dan, I like to ask contentious questions. So at the end of the induction phase with the tasty and healthy diet, I'm sure patients feel very healthy, but do they perceive it as tasty as well, the whole diet?
Well, that's why we put a lot of effort in providing nice recipes. If you look at the book, and there is another 2 more editions coming in different languages, and families are sharing. Really, you can, if you put effort into it, you get a nice diet, and that's true for everything. If someone, if a Jew keeps kosher, he needs to think about what he puts into food and where he or halal or whatever, and he needs to decide what he wants. I decided I'm vegan, so I need to think about the food I'm eating and what am I preparing, where I'm buying the food. So this is a conceptual, personal decision. It's a state of mind. If you say, that's how I decided I want to live because it's good for me for any reason, then you make the effort. Truthfully, it's not suitable for everyone. We have many patients that are on sole diet, and that's it. They don't get anything else. They are very happy. The child is happy. The parents are happy to make the efforts, and they feel better. They see no inflammation whatsoever, calprotectin 0, transmural healing. So everyone are happy, and that's fine. Again, if you cannot reintroduce gluten or dairy, it's more challenging. We have families like that, but not many. So the essence is to see who can, after 8 weeks of induction, introduce some of the foods.
Dan, that was a very tasty recipe for our IBD practice. So we got to rally our dietitians, get them trained up before they realize we have added 20 new ingredients to their workload. Anyway.
And this is true because you have to have dietitian with any exclusion diet. You cannot do that without, because some patients it results in unbalanced diet, and then for some of them maybe supplement with formula is okay just for the sake of balanced diet. For some of them just nutritional counseling, but any exclusion diet needs a support of a dietitian.
Absolutely. So shifting gears from diet to drugs. Now, before the biologic era, monotherapy with immunomodulators such as azathioprine, 6-MP, methotrexate was central to IBD management for several decades. Now, with the biologics coming in and small molecules, has your practice around monotherapy changed? Because in the adult IBD world, if I refer to the recent BSG guidelines, and in regions like North America, there's a noticeable shift away from immunomodulator monotherapy. What's your perspective on this trend?
Well, I think, my practice changed a lot also because now with the biosimilars, some of these drugs are cheaper than prescribing budesonide enema. And that's easier to give. Azathioprine is a great drug for ulcerative colitis, so a step-up approach that still should be right. I have patients that I came to my clinic elsewhere when they started already vedolizumab and they were active. All I did is stop the thing, went down to thiopurine. The patients are in complete deep remission. So thiopurine is a great drug for ulcerative colitis. So 5-ASA, then thiopurine, then biologics. That's for ulcerative colitis. For Crohn's disease, only if the patient has really mild disease and you can think of they don't want nutritional therapy, because in these mild disease, you come in, there's a few erosions in the ileum, it's not really cobblestoning or deep ulcerations, then you can think about immunomodulators, and we can discuss the safety and what is the profile of patients. But maybe 15%, 20% of Crohn's patients will enjoy immunomodulators. I moved away. I used to treat a lot with methotrexate. We published quite a few papers regarding methotrexate. Before we had lots of biologics, like that's 20 years ago, we had a paper of those failing azathioprine, what happens when you move them to methotrexate, and 30-40% of them go into complete remission. And that's what we used to do then. That was our switch. I think we moved away from it. Methotrexate, half of them, they have nausea, so I kind of stopped using it unless it's with combo therapy with biologics. So I would say that for safety-wise, azathioprine for ulcerative colitis or for the mildest cases for Crohn's disease, that can be done in low-resource countries where biologics are not available or very partially available. And definitely we can use azathioprine or methotrexate. They are beneficial in some of the patients, and then we need to think about the dose because of the concern about all kind of safety things that I'm happy to discuss in a second. It's in the end of the day, it used to be 3 milligrams per kilo. I mean, this is the G. Markovich famous trial. That was the dose. And I remember when I was a resident and we didn't have biologics and we didn't have levels, we used to dose up until we saw the lymphocytes going down and there was mild leukopenia. And that was the dose that was right for that patient. And then we could see effect. But we are dosing too low with the concern of the lymphoma, which is so rare. We just presented it. Will be presented at ESPGHAN as a presentation in one of the major sessions with 2 nationwide studies with Sweden and the EPIRN from Israel. And we took all lymphoma cases. We took thiopurines and anti-TNF, and we because it was 2 nationwide cohort. It was a huge sample size, and we managed to correct the lymphoma rate that was. We had hundreds of events with that and the controls. We managed to control for disease activity over time, and lo and behold, disease activity is more influential or more causative of lymphoma than it is the actual treatment. Because if you look at the older treatment for thiopurines, you can see that the hazard ratio was 4 or 5. That's when thiopurine were given to the sickest patients. And then in the recent years, then thiopurine is now in the recent cohort goes down to 1.5 or 2. And from Scandinavia, it wasn't even significant predictor of lymphoma. And anti-TNF suddenly becomes a significant associated with lymphoma, just because anti-TNF now is associated with a more severe disease. So there is the hepatocellular T-cell lymphoma story, which is totally real. And there is the HLH story, which is definitely real. But the other bulk of lymphoma that we were seeing and driving this hazard ratio of thiopurines are probably at least partially confounded by disease activity.
Very, very interesting, and a lovely example of how data can really pick apart some of these kind of, I would hasten to say old wives' tales, but certainly misinformation that gets spread very easily, and important for our patients, many of whom may be listening, to understand sort of the risk benefit of these treatments and why we might push one rather than the other. And you touched upon combination therapy, specifically things like immunomodulators with anti-TNF. And since the SONIC trial, guidelines have consistently supported combining these immunomodulated drugs like the thiopurines with anti-TNF therapy. In your practice, how long do you typically continue those thiopurines when you've used them with an anti-TNF agent? And how do you approach de-escalation?
Okay, so definitely and I think that's also in the guidelines, but my first line therapy for biologic will be adalimumab, because the effect size of giving combo therapy with thiopurine or methotrexate is not so large, because the immunogenicity of adalimumab is lower than infliximab. If you start infliximab, usually you want to start with immunomodulator. So if the patient is not in particularly high risk, then I would give monotherapy of adalimumab. If the patient is started with infliximab for any reason, then it's best to start as combo therapy. And if the patient is particularly high risk. So he had panenteric disease, he had already stenosis, he had, stunting growth. You want something, this patient, you want the best effect. So wherever this is adalimumab or infliximab, you want combo therapy. Other consideration that we'll have, this is a female or a male. So with females, the risk of hepatosplenic T-cell lymphoma is really low. And the other question is EBV positive or negative, because if it's positive, then the risk for HLH is really low. So these things I take into consideration in the gray zone to decide and in the shared decision making, so I can communicate the actual risk. Whatever happens, unless this is really, really high risk patient, and then the risk needs to be discussed with the family. Then after 6 to 9 months, I will measure levels. I will measure level even before, but after induction, but I will measure levels again. And if the levels are high enough, then we will discuss together to remove one of the treatment and leave one of them, usually remove the immunomodulators and keep the biologics. I want the levels to be higher because we remove the immunomodulator, the usual, on average, the levels will decline a little bit. And we need to discuss this with the family, that there is a risk of 10-15% that the patient will develop antibodies and will need to increase the dose or even switch therapy. But I think for most patients, this approach is reasonable by balancing the risk and the benefit of the treatment.
Yeah, thanks. And on that point, when you're looking at, when you say levels, you're talking about the anti-TNF levels, of course. But when you're measuring metabolites, say 6-TGN, which is one of the main active metabolites of the thiopurines, do you aim to keep them firmly in what would be a therapeutic range, or when you're using them as an immunomodulator, do you accept if they're slightly low because they're not having a primarily therapeutic effect? They're there to aid the use of the biologic agent.
Yeah, definitely. When you give it as a combo therapy just for the sake of immunogenicity, most data, not all data, but most data from adults, from rheumatology, even for pediatrics, say that it's probably, you can go down with the dose. You can start with 1.5 milligram per kilo for azathioprine, and if for methotrexate, you can give oral 7.5 or 10 milligrams. That for adolescents, you can work your way down with the dosing. If you have a smaller child, well, body surface area adjusted dosing. But sometimes if I have acute severe colitis at diagnosis and we want to start infliximab because the patient is steroid refractory, and with that, as I said, with infliximab we start azathioprine, I will start full dose because something will work, and then I can work with the dosing later once the remission has been achieved for that patient. So you need to work around. Sometimes you do need the higher dose. We have to remember that quite a lot of the toxicity of thiopurines is dose dependent. So lymphoma is dose dependent. If 6G is higher, you have higher risk of lymphoma, hepatosplenic T-cell lymphoma, and the same thing goes, of course, to cytopenia. For liver enzymes, it's more 6-MMP, but this is also, in the end of the day, it's dose dependent if TPMT is normal. I try to do levels on all of my patients. Not if the patient is good and the CBC is normal, I would not chase levels specifically, but it's still something to consider when you're looking at the monitoring of the patient.
Dan, I think you briefly touched on this. So when we counsel patients about the risks before we start them on these medicines, parents often ask about the risk of malignancy, whether on monotherapy or on a combination. So what's your go-to way of explaining these risks in a clear and reassuring manner?
Well, I tell them that there's one. I tell them about all the risk of all the drugs, and then I tell them there is one thing I have to tell them, because otherwise they will look at it in ChatGPT and get freaked out, and I don't want them to get freaked out. So I'm going to tell it to them and then erase it from your conscious. And I'm going to tell you that the treatment, whether thiopurine, methotrexate, whatever I'm giving, has a twofold high risk of lymphoma. That's how, even fourfold, depends if it's a girl or a boy. I will adjust what I'm saying to them. And I'm telling them that it sounds frightening, but really it's like buying 2 or 3 tickets to the lottery. You have 2 or 3 high-fold risk of winning, but still you will not hold your breath on Sunday morning to rush in to get the paper to see if you actually won. And they said, oh, yeah. And I said, look, you went into the car and came to my clinic to see me. You didn't expect this to have 1 in 700 risk of being in a significant car accident, because that's a risk. So we all accept risk in what you do. And did you fly over the Atlantic? You increase your risk for cancer. Did you do barbecue? You increase your risk for cancer, etc., etc. So this is something, and I say for when we did for the EPI-RN, we followed all children treated with thiopurines for the last 20 years. We followed them to the age of 30 in that cohort. We could not find a significant difference of lymphoma between those treated with thiopurines or those not treating at all with anything. There was a little bit high risk, but it was not even significant. So that's what I'm telling, giving them the data. Usually they say, oh, okay, but it's really important. It's really important to do it in part of shared decision making. Shared decision making is not just a term; it's practice. It's divided by 3 chapters. Chapter 1. Give a sincere feeling to your patients and to your family that they have a choice. And they do have a choice. They always have a choice. Even if we think there's only one thing they should do, they have a choice to treat, not to do anything. It's still a choice, and it's theirs to make. The chapter number 2 is the options. And be honest in pros and cons of all of the options. But if you play your cards right, in the end, in the 3rd chapter, which is the decision chapter, they will follow your advice, and in most cases, because they had the option of considering accepting other options. So most families will be okay with that. And in that shared decision making, if you give that in an honest way and you give the pros and cons of all other options, it's very clear why you think, even with that negligible risk, it's good to go in that route, if that's what you feel.
Thank you. And again, you have mentioned this earlier about EBV serology, which frequently comes up in decision making, especially given the risk of HLH in EBV naive children, that is, children who are not exposed to the EBV virus. So how do you integrate EBV testing in your practice, and how does EBV status shape your decisions around initiating or avoiding thiopurines in pediatric IBD?
Yes, thank you. HLH is a real thing, and it's more real than hepatosplenotic T-cell lymphoma. Also, hepatosplenotic T-cell lymphoma is real, but HLH is more common. It's still rare, but it's more common, and it could be deadly. So we had 2 cases in the EPI-RN. We had no hepatosplenotic T-cell lymphoma in the entire state of Israel for 20 years for any child. But we had 2 cases of HLA. One of them died. We had in the develop registry, that was quite a few years ago. Jeff Heim was leading that paper. Again, there were 2 or 3 cases, maybe more, maybe 4 cases of HLH. Again, there was 1 or 2 fatalities. So HLH is a real issue. Means that A, we need to discuss it. B, we need to look at EBV. And C, we need to have awareness to that, and if that happens, an early diagnosis and treatment is really life-saving. So, if EBV positive patient, I would be more happier to start thiopurines, especially if it's a girl. So, it's a girl with positive EBV, the risks are low. If it's a boy with EBV negative, then the risks are higher. A lymphoma, B HLH. And this is something that we discuss with the patient, and anyone with thiopurines that are coming with fever, hepatosplenomegaly, with stormy presentation that looks like sepsis or something bad is going on, you can think about it. We'll think also about HLH.
Yeah, thanks, Dan. I was just hoping to finish this episode, this part of our sort of 2-part series, thinking about biologic therapy. We talked obviously a bit about immunomodulators, thiopurines, methotrexate. And I was going to ask you about your approach overall to biologics, but based on what we've been discussing, I think it's going to be quite nuanced. I think you go with the data probably, and maybe it differs for different patients. But do you have a general approach, whether you go top down or step up, or is it purely about who the patient is in front of you?
Well, I think we have to stratify a patient to risk. So even before we go treat a target, we can usually stratify a patient to low risk and moderate risk, high risk, in particular high risk. And those on the low risk can be or without treatment. There are our adult colleagues are doing that all the time. But for me, no treatment means nutritional therapy as much as possible, and or thiopurines or as I said, no treatment, but that would be quite rare. The moderate and severe or the moderate and the high risk will probably start with biologics. For me, it's adalimumab, biosimilar, very effective. It's safe, it's cheap. I would not start with other biologics like risankizumab as the first line, especially that is not labeled in children. In some countries, it's labeled over the age of 16. But definitely, this is something that we are waiting data to see if it's more effective than anti-TNF. The IL-23 and ustekinumab are probably a little bit safer than anti-TNF, but this is so remote because the vast majority of patients on anti-TNFs do very well, and I think it's a safe drug. For the very high risk patients, I start combo therapy, whatever happens. So they will start or infliximab or adalimumab with combination therapy, and then only after a few months, when you reach your target, then you can think about de-escalating. But it doesn't matter what you started, because the immediate response to treatment is probably the most important predictor we can think about. And it doesn't matter what you're giving, steroid, nutritional therapy, biologics, those are responding very well within a few days. They will continue doing well. And those you're waiting 2, 3, 4 weeks and the patient is still active and it's not the same, these patients take into consideration, if you didn't escalate therapy, escalate and increase and combine and do what you need in order to get to the target. And the target means it's not only the patient feels well, but the inflammation starts going down. I do not expect fecal calprotectin normalization or transmural healing within 8 weeks. I don't care about that. I don't do endoscopy after 8 to 12 weeks. You need to see a trend, and the trend needs to be very consistent. And if that is not being achieved, then very quickly do something. I think the most common mistake we can do is to take a patient, to give him something and said, okay, come and see me in 4 months. We need to follow our patients and have a system that we follow our patient, even not in clinic, but someone needs to be in touch with the patient and see what's happening and changing and be ready to change treatment rapidly.
Yeah, I think that's the benefit of something like infliximab, I suppose, where generally speaking, it's infusion rather than subcutaneous, where you're actively seeing the patient each time you give the drug, which perhaps you don't get with the subcutaneous therapies. The one biologic you didn't mention now, or one of the biologics you didn't mention, was vedolizumab. Now, that may come to license soon, hopefully, and there's been some sort of talk about whether that might be a first-line biologic for ulcerative colitis. Now, the key part of that, as you said, is how quickly these drugs act. And vedolizumab, for some children, does seem to take a bit of time to have its full effect. Would you ever consider, or have you ever considered giving Vedo as a first-line biologic therapy for your patients?
Okay, so first I want to correct something that I said before. I said adalimumab is my first choice, but that's for Crohn's disease. For ulcerative colitis, my first choice is infliximab, and it seems that it's a little bit more effective and better than Crohn's. And then I don't mind combining it with thiopurines, because I know that thiopurines is a very good drug. And usually when I start biologics, it's after failing thiopurines. And then anyway, they have the thiopurines, and all I do is I add infliximab. And if I start infliximab from the outset at disease diagnosis because of acute severe colitis that fails steroids, then as I said, I give both of them because I don't know what will work best. So that's an easy choice for me with infliximab. Would I change or had I changed my practice to vedolizumab? Well, truthfully, I think cost matters. Cost matters, and we don't talk about cost enough on the podium. We talk about efficacy and safety as if cost is none of our concern. What it is, because the medical system, especially in the middle and low resource countries, but also in the Western countries, cannot accommodate everything. And if I have very good drug, which cost 1/7 or 1/10 of the cost of another drug, now I don't need to convince you why I'm giving the cheaper drug. You need to convince me why not to give the cheaper drug. So what is vedolizumab better than infliximab that I need to pay 7 times more than I pay now for infliximab biosimilar? So you might manage to convince me, and I convince myself, when there is high-risk patients for safety. So if someone had prior cancer or general or any immune deficiency or some, I don't know, something, or huge concern of the family. You can see the family is just, they are sweating. There are some families that go into this storm of anxiety that the only way is just to do something else and to do, and that's fine. So I have this patient. The vedolizumab is very good drug for ulcerative colitis, not so good for Crohn's, okay for Crohn's colitis, as we have shown in the VedoKit study that was published in a couple of manuscripts. So that will be my choice when vedolizumab is both registered in children and becomes also biosimilar, and that should happen in a year's time. Then I'm happy to give either vedolizumab or infliximab for ulcerative colitis. There is no data to suggest that vedolizumab is better than anti-TNF. I mean, we all know Varsity, and Varsity compared vedolizumab with adalimumab. There is a reason why they chose adalimumab and not infliximab for ulcerative colitis, because adalimumab is inferior. There was no combo therapy for adalimumab, and there was no correcting for anti-TNF levels and shortening the interval, because this is more sensitive in anti-TNF than vedolizumab. And still, the number needed to treat was huge, was like over 10. So you needed to treat many patients in order to get one response. And tell me, is there any downside in ulcerative colitis when you give anti-TNF and it doesn't work after 3 months? You change to vedolizumab or upadacitinib or tofacitinib or one of the other drugs. Do you miss anything? I would say for ulcerative colitis, definitely no, because treating earlier, getting better response has been proven only in Crohn's disease. And there are various studies, population-based, including ours from the EPIRN, that if you give the biologics in ulcerative colitis in the beginning, after 1 year, after 3 years, you get exactly the same effect. Unlike Crohn's disease, where time is important.
Dan, I think we are nearing the end of the podcast, but I do have a final question. And if I roll back to the whole food diet, which is used as per the paper in mild to moderate Crohn's disease. So if you have patients who are a bit on the severe spectrum of the disease, would you consider using the tasty and healthy diet alongside additional therapy like biologics, steroids?
So there are data to support adding nutritional therapy to biologics, and nutrition therapy have been shown for Mediterranean diet, for seeded, and we have shown that in the second RCT, which is, as I said, it's back and forth with the reviewers in one of the journals that will be out very soon, and you can see those who are on asymptomatic with biologics but didn't get the full effect. When you add diet, you get better effect. And if you do give, but this is combining therapy. I think that's the topic for our next podcast. But combining therapy is not only combining biologics. It's not only combining thiopurine. Nutrition is therapy. So if you take biologics, or you take biologics with nutrition, you just combine treatments, and combining treatment always you will have a better effect. The question is, of course, always, what is the number needed to treat? So just showing a p-value that with nutritional therapy is a little bit better without doesn't mean that we need to practice this for all patients, because I'm not so sure it's fair. So we need to think about who are the patients, as you said, the most severe patients that you really concerned about getting rapid control of their disease. That will be a reasonable approach to ask them to make the extra effort and to give. But I'm telling my patient with nutrition that are starting biologics that their inflammation in the gut, it's like a bonfire. And from one side, the pro-inflammatory foods is oil. And from the other side, the biologics is water. In some instance, the water is so effective. Whatever oil you put on the fire there will be no fire. In some people, there is still a lot of fire despite the water. And then, if you limit the oil, it becomes better. And what I'm trying to explain in that example is that it's not all or none. And sometimes if you are on biologics and you keep the principles of tasty and healthy or the principle of another diet, even if you are not adhering to it 100%, still you reduce the burden of inflammation and you allow the biologics to work better.
Dan, thank you. I wish I had an impromptu ode up my sleeve to capture just how fantastic this discussion has been. Truly, it's an immense privilege.
Thank you.
Thank you. Dear listeners, like us, I'm sure you have been eagerly awaiting this Dan Turner episode for a while. And the good news, you get a double dose. Professor Dan Turner will be joining us in the next episode as well. So don't go anywhere. In the next episode, we'll have another feast of IBD wisdom waiting for you. But for now, goodbye and take care.